Mary, shall we start or we'll wait for some more time?
It's just 4.
Just 4. Shall we wait for 2 more minutes?
Yeah.
Yeah. Okay.
Able to, no, ma'am?
Yes.
Yeah.
Yeah, no. She has to, I think, relog, no?
Lakshmi, can you put the CV out?
Yes, ma'am. Aruna, ma'am, you just stop sharing. I will tell you when to share. Thank you.
You are in mute, Aruna. Unmute yourself.
Mary, ma'am, let Vali, ma'am,
Yeah.
start and then I will share.
Yeah.
Yeah, now got it. Perfect.
Okay.
Shall we start?
Yeah.
Yeah. Good evening. I, Dr. A. Sundravalli, convener of NSI Bangalore chapter, take the pleasure in welcoming you all for the last virtual webinar of the webinar series on knowledge sharing with recent update of nutrition. Today we have in our midst Dr. Aruna, who will be sharing her rich knowledge on the role of MNT in metabolic disorders. Dr. Aruna is known to me for more than 4 decades. She's my younger sister, and she has a passion for teaching. I request Ms. Mary Reggie, co-convener of NSI Bangalore chapter and associate professor of Department of Nutrition Dietetics, Mount Carmel College, to do the needful to introduce our speaker, Dr. Aruna, and moderate the session. Over to Ms. Mary Reggie.
Thank you, Sundravalli. You can hear me?
Yes.
Yes. Okay. Good evening to one and all. Thank you for accepting our offer of delivering your talk during this time. And we're extremely happy to have you, Dr. Aruna. I will introduce the speaker for today. Dr. Aruna completed her MBBS from the Madurai Medical College in the year 1989 to 1993. She studied there. She completed her MD in internal medicine in 2002 from the Interfaith Medical Center, New York City, USA. She completed her fellowship in diabetes, metabolism, and endocrinology from the University of New Mexico, USA. She's also a member of the American Board Certification since 2005 for diabetes, metabolism, and endocrinology. She's a consultant and division chief from the year 2004 to 2018 at WellSpan Endocrinology, WellSpan Health, York, Pennsylvania, USA. She has a passion for teaching, and she has been teaching from the year 2004 to 2018 at the Internal Medicine Residency Program at the WellSpan, York, Pennsylvania, USA. She's a consultant endocrinologist at present, working since June 2019 at the Alpha Hospital and Research Center, Institute of Diabetes and Endocrinology, Madurai, Tamil Nadu. She has been attending and a mentor for medical students and nurses, practitioners, and physicians for many years. She headed the clinical effectiveness team for inpatient and outpatient diabetes management for WellSpan Health. She authored the guidelines for inpatient and outpatient diabetes management for WellSpan Health. She headed the quality assessment and improvement projects for diabetes, metabolism, and endocrinology at WellSpan. She led the WellSpan Endocrinology to be recognized as the first specialty patient-centered medical home in central Pennsylvania. She designed the CPOE, that is the Computerized Provider Order Entry System for electronic medical records for inpatient and outpatient diabetes and endocrinology at WellSpan. She assisted with the diabetes management protocol for preoperative and intraoperative and postoperative cardiothoracic and orthopedic surgeries to reduce post-op infections, morbidity, mortality, and the hospital stay. She has standardized the workflow process at WellSpan Endocrinology. She helped the formulary management and risk reduction Department of Pharmacology, York Hospital, and WellSpan Endocrinology, WellSpan Health. Ma'am, we are extremely impressed by your and we are looking forward to hear from you, ma'am, because you have a lot of experience in this area, which is a very, very close area to our hearts. Thank you, ma'am, and welcome. Please take the platform.
Dr. Aruna?
I think, ma'am, her connection is not there.
I'll call her.
She's there, ma'am. She's there. I think she rejoined. Wait. Yes. Aruna, ma'am, you have to unmute.
Yeah, is that good?
Yes.
Good, thank you. Okay. Okay. My apologies. Good evening, and thank you very much for Dr. Sundravalli for your kind introduction, and Dr. Mary for your kind introduction. It's an opportunity and pleasure to be here. And definitely diabetes and nutrition is my passion. This is a huge topic. I hope today that I would be able to do justice to this topic. So without much ado, let me go ahead. So diabetes is a huge topic. My sincere apologies. I have no idea why this is happening. Always never had any issues with
You can put slideshow, ma'am. Yeah.
slideshow, yes. Never had any problems with the Zoom meetings. Today looks like not my day. Okay, here we go. So metabolic disorders are wide, and we have something called dyslipidemia, and a bunch of which leads to severe obesity, in fact, elevated blood sugars, insulin resistance, and hypertension. So it's a wide area of topic, but today I'm going to primarily focus on diabetes. So the agenda today is going to be just world and Indian statistics, and why Indians specifically are very high risk for diabetes, and what is diabetes overall, a very short pathophysiology, classification and complications, investigations and pharmacological treatment. And finally, the segue into medical nutrition therapy. I would like to get over so we can have a Q&A session. So statistically, we can see the big error here, and Southeast Asia, which is primarily India. In 2017, we have 82 million population known diabetes. By 2045, it will be 151 million. And all over the world, it is increasing. And Africa is a ticking time bomb. If you see, there's going to be 156% increase in diabetes. So battling in India, there is 7.3%, that is 69.2 million. I'm going to try hotspot and then do it. Can you, if you just give me a few minutes? I think it's because of my bigger megabytes. I'm not really sure why it's hanging. So diabetes is going to be economically major issue.
Your slides are not seen, Aruna. Yes, slides are seen.
She has to unmute.
You have to unmute yourself. Audio. I think without slideshow also you can carry
Got
on.
it. So here we go. So within from 10-year survey, this you can see that even okay, so the facts is India is going over, and we are having a whole lot of this one.
Aruna, the
And,
slides are not moving.
1 in 4 people under 20.
I think, ma'am, her connection is temporary going also.
Yes, yes, yes.
No?
Would you like to send your slides, no, share your slides with, send it. Lakshmi,
Yes, ma'am.
the file is coming to you. Okay.
Okay.
After sending, participants, just 2 minutes. We will start again. Sorry for the inconvenience.
Ma'am, it will come in my email ID.
It will come in Gmail, NSI Bangalore chapter.
Okay, fine.
Hello, you can come online. Yeah, you can start. Video poda venda. You don't put the video. Okay. And Dr. Aruna, you can unmute yourself. Unmute yourself. Dr. Aruna. Unmute.
Wait, ma'am. I think I need to wait.
Unmute her. Yeah.
Now, what is her? In which name she has signed, ma'am? Just ask.
Which one?
What's her name in ID in Zoom? Not
HP.
No, I think now she came as Aruna.
Yeah.
Okay, wait 1 second.
Aruna, you wait, no?
Yes.
Now you are audible, Aruna. You can start.
Audible. Okay, so. Okay. Do you see this slide by any chance? By any chance, is it? Do you guys can see it? I am just focusing my phone over it.
No.
No, you are not able to do it.
No.
Okay, no. I'll just go ahead and talk then, if you don't mind.
Yes.
Okay. So, okay. So primarily, I think I've gone over the diabetes.
Have you sent a PPT, Aruna?
Akka, the email is even not opening up, Akka. So that's the problem with this. I will do it. So quickly, I'll just review. I'm not even able to open the email. I'm not sure what's going on here. I should have sent you early. My sincere apologies. So having said that, why Indians are higher risk for diabetes? So it's because of Asian Indian phenotype. We call the thin, obese, thin in the extremities, obese, mid-abdominal obesity Indian males, or Indians, we call it. So this applies to all Southeast Asia, not only just us. So where you have severe insulin resistance because of the visceral fat, that's fat around the organs, which causes severe insulin resistance. So you're not able to use the glucose metabolism properly. So that results in diabetes. So that's unfortunately, genetically, we are high risk. But primarily, if you really look into it, diet tops everything. Reason that such a high increase in diabetes is because of the diet that is involved. And physical inactivity with Indians, then comes the genetic predisposition before industrialization and other causes that causes diabetes. So like plastics. So what is diabetes? So diabetes primarily is a chronic condition where you're not able to utilize glucose. So there is accumulation of glucose in your blood as well as another organ system causing damage. So how do you use glucose? Primarily, it's through your hormone called insulin. So insulin is not a medicine, it's a hormone actually. And whether you produce insufficient insulin or your inability to appropriately use insulin, that causes high sugars, and we call it diabetes. So classification. So diabetes, there are different types of diabetes, primarily two types that you really go for. One is type 1, the other one is type 2 diabetes. So type 1 is juvenile diabetes, where the kids get it. Type 2 is adult onset diabetes. The other ones are genetic defects, secondary causes, secondary to injury, secondary to chemical injury or trauma or other cancer. So we call it secondary diabetes, where pancreas is affected, or secondary to certain drugs. And then finally, gestational diabetes, that is diabetes that occurs during pregnancy. So what's the mechanism? What's the difference between type 1 and type 2? Very, very important. Type 1 is where you are not producing any insulin from very young age. So you're completely dependent on insulin to dispose the sugar. So if you don't have insulin, you will die eventually. So whereas type 2, you do make insulin, but that the insulin is not enough, or that liver is not able to make use of the insulin. So we call it insulin resistance. So that's type 2, which is the adult onset diabetes. Unfortunately, type 1 diabetes is supposed to be very, very small percentage. It's trending up about 3 to 5%. That is, we see 3 new cases of diabetes for every 100,000 children from age 0 to 14. That's really scary. So that means these children have to take insulin hormone for the rest of their life to be alive. So gestational diabetes, what do you call gestational diabetes? So gestational diabetes is where, as we all know, we carry the baby. We are not able to handle the carbohydrates, so because the insulin production is not enough or insulin resistance is too much. And that results in accumulation of sugar, calling that as gestational diabetes. So what if the patient has diabetes ahead before even she got pregnant? Then we don't call that as gestational diabetes. That's a pre-existing diabetes. So this is something that develops during pregnancy and usually resolves after pregnancy. But the patient or the mother is higher risk of developing diabetes future, like 5-10 years down the line. And also gestational diabetes, if your mother had diabetes, you are also very high risk, and your daughter will have high risk of developing gestational diabetes. So what does it do? Unfortunately, gestational diabetes is very high risk pregnancy. Mother can die and baby can die from various complications, fetal death, macrosomia, or cesarean section. There's so many complications of gestational diabetes. So what's the natural history of diabetes? Do we develop diabetes overnight? Unfortunately, no. So diabetes is a very gradual process over 10, 15 years, where we call pre-diabetes state. So in pre-diabetes state, where your sugars are just subnormal, they are not in the normal range, they are subnormal. So where it still causes damage to your organs, then eventually you reach the criteria, you are called full-blown diabetes. So once a diabetic, you're always a diabetic for life. And if you continue to not address your diabetes, you end in diabetes complications. So the major diabetes complications, we divide them into two. One is macrovascular, the other is microvascular. So microvascular means small organ systems, peripheral nerves like eyes, kidneys, and nerves are damaged, and multiple other things. Pretty much my dad's mentor used to say, if you know syphilis, you know medicine, because it affects every organ system in the body. So today I do say that diabetes, if you know diabetes, you know medicine, because it pretty much affects every organ system. And if you don't address diabetes, the outcome is very poor. So the major vascular complications, of course, is stroke, your brain, and myocardial infarction, that's your heart. And if you have peripheral vascular neuropathies, you can lose your limbs. So those are macrovascular complications. So how do you know whether you have diabetes or not? Most of the time, diabetes is without any symptoms. But when your sugars are really high, you will feel very thirsty, you urinate frequently, you have weight loss, exhausted, blurry vision, headaches, So especially if you have a family history, I would advise you to go ahead and check. So what do we do? So investigations, obviously random blood sugar or fasting blood sugar, or we make you eat a meal and come back in 2 hours and check your blood sugars. So when do you say that you have diabetes? We say you have diabetes when your blood sugar level is above 126, or you're 2 hours after a meal if your blood sugar is over 200, or any time your blood sugar is over 200 with symptoms, we say you have diabetes. So the pre-diabetes, that means your fasting sugar over 100 definitely puts you at pre-diabetes. Your postprandial, that's after meal blood sugar greater than 140, puts you at high risk for diabetes. So when you go to the doctor, we do at the first visit, besides diabetes, we check your kidneys, heart, cholesterol panel, foot and eye examination, and we also do basic blood pressure, weight, thyroid status, and nutritional deficiencies. Diabetes patients are very high risk for nutritional deficiencies, especially vitamin B12, vitamin D. So it's very important you do that. So where do we go from here? Comprehensive care plan. So how do you treat? So it's a treatment modality involves multiple pronged approach. One is, of course, pills, which we all know about it. Other is therapeutic lifestyle changes. Then comprehensive diabetes self-management education for patient empowerment to manage their own diabetes. And finally, all the other disciplinary systems, an eye doctor, dentist, foot doctor, heart doctor, everyone comes together to help the patient in managing the diabetes. So it's not a one doctor's disease, it's a team. So diabetes self-management, what exactly this involves? This involves a patient having knowledge about diabetes, healthy eating, and being active, how to monitor the sugar, taking the medications on time and appropriately. And if they have problems, they need to know how to solve and when to call the doctor, whether the sugar is high or low, or did they nick their feet, they have a wound that's not really healing, they should know when to call the doctor. They're not able to afford their medications, then reducing the risk. So how do I prevent a major heart attack? How do I prevent a major stroke? It's very important they know that. So that's really a great one, which we have something called Diabetes Education Program in the United States, where we do a 10-hour class for our patients. It's carried by our certified diabetes educator, accredited by American Diabetes Association, which also involves 4 hours of medical nutrition therapy. So where does medical nutrition therapy comes in? It comes under the component of therapeutic lifestyle changes. So healthful eating and consistent carbohydrate intake, limiting the high glycemic index, and taking adequate proteins, being mindful about the micronutrients. This is medical nutrition therapy. Heart healthy diets. So diabetes goes hand in hand with cholesterol, so we need to address that. Sufficient physical activity, approximately 150 minutes per week, that is 30 minutes a day they have to do. Sufficient sleep, avoidance of tobacco products, limited alcohol consumption, stress, and weight reduction. Both has to be reduced. So that's lifestyle, therapeutic lifestyle changes. So before we go into the broad spectrum of medical nutrition therapy, I'm going to go into pharmacological management, give you a synopsis what medications on board. I'm not going to go into details, don't worry, but as a nutritionist or dietitian, registered dietitian in diabetic management, you need to know, because certain medications cause certain side effects, they cause nutrition deficiencies, vitamin deficiencies, and you need to understand that and appropriately counsel your patient and ask the patient to watch for. That's very, very important. So there are multiple medications in pipeline, almost 10 categories of them. The most common of them is called metformin. And metformin definitely helps with insulin resistance. It decreases the weight of the patient. It is one of the medication more than 50 years old, fairly safe. But the biggest issue with this metformin causes GI side effects. They do cause a lot of flatulence, gas, that means, and also vitamin B12 deficiency. So you have to counsel the patient on nutritious diet that's rich in vitamin B12, and also make sure the patient is not experiencing any peripheral neuropathy, and they are not also experience any dietary side effects, like if you prescribe high fiber diet with this medication, they may have a worsening of their effects. So that's something you need to know. Sulfonylurea is one of the oldest medication. The biggest issue with this is significant weight gain and low blood sugars. So it's important to counsel the patient to not to skip their meals, eat their carbohydrates on time. That's very important for this medication. And help them with the weight loss diet and avoiding unnecessary or what you call bad carbs. They have to, so this will prevent them from gaining weight too much. So pioglitazone, this is a great category. We use this for severe insulin resistance and fatty liver management. Again, unfortunately, it causes severe osteoporosis, that is brittle bones. So you guys have to really think through that and say, hey, you need vitamin D diet that's really helpful for your bone protection, calcium-based diet for your bone protection, and avoid salts because this causes heart failure, because it causes increase in water retention. So cut back on your salt intake. So this is how a nutritionist or dietitian really matches the drug and nutrition interaction where the changes needs to be recommended. So next is alpha glucosidase inhibitors. It causes severe GI side effects. Again, high fiber diet is not recommended. Highly recommend to give, a little bit, especially older folks, they already have GI issues, or patients with type 2 diabetes on a long-standing has nerve affecting their stomach. So this is called gastroparesis. The stomach doesn't move, so they actually retain food. So it causes increased bloating, abdominal pain, discomfort, diarrhea. So this medication also causes similar effects. So you need to give them the gastroparesis diet that helps. That's a soft diet, actually, not rich in fiber, which helps the patient. So the latest medications are incretin mimetics, DPP4 inhibitors. Not a big deal about this other than low blood sugars. You have to be careful about that. The final one is the latest rage SGLT2 inhibitors. It's an awesome medication, works through the kidney. Biggest issue, it can cause hypotension because you pee a lot, you urinate a lot because that's how you get the sugar out. Patient can get dehydrated. So it's very important you tell the patient to drink water. Water is an important part of your macronutrient, even though we don't, but I do consider that's part of the diet where, unfortunately, diabetes patients don't drink water. They get dehydrated very easily. And this medication makes it very bad. And also, their weight loss, significant weight loss is noted. You have to really help them. And it also increases the bad cholesterol, LDL cholesterol. So you as a dietitian need to remember that and tell them, hey, you need to cut back on your fat intake, the bad fats, of course. So here's why knowing the medication for that particular patient is so important. So besides pills, of course, insulin. Eventually, when the pills fail, as I said, type 1 diabetes, that's juvenile diabetes patients already on insulin from childhood, but type 2 patients also like 10, 15 years into the diabetes, the pancreas fails. So they will go on insulin. There are multiple, again, options of insulin. You need to know about insulin to some extent, not like the doctor, but you need to know because there are very, very rapid, fast-acting insulin, very slow-acting insulin, and there are also very long-acting insulins. So you have to be very careful about that. And insulin is primary thing that is we are afraid when we initiate insulin is hypoglycemia, low sugar. So this is where very important the dietitian's role is to insist and to review and let the patient know importance of taking carbohydrates at the right amount at the right time throughout the day, which prevents hypoglycemia, which prevents hyperglycemia, which prevents also weight gain. So this is very, very important, especially with meal timings and the insulin timing and the amount of carbohydrates they're taking is very important. Where, oh my God, I can't say enough how much I rely on my registered dietitian to help me with the patient to understand the concept and to adhere to the regimen that I recommend. So having said that, why do we need to improve sugars? What's the problem? Yeah, the thing is every drop in A1C, that's the glycosylated hemoglobin, you improve or prevent complications of microvascular by more than 43%, major macrovascular like stroke by 12%, heart attack by 14%. Just drop in 1% of hemoglobin A1C. You know how much percentage you can drop A1C by just medical nutrition therapy? You can drop by 1 to 2%. So if a patient has a 9% A1C, 2% just by changing the diet, he has dropped his A1C to 7%. That's the target. He is having a better or well-controlled diabetes. You are preventing complications. So I hope you understand the importance of the counseling, nutrition counseling. So moving on to the most important topic of the day is medical nutrition therapy. So what it is, you define it. It is a nutritional diagnostic therapy and counseling service for the purpose of disease management, which are furnished by a registered dietitian or a nutrition professional. So as per ADA, that American Diabetes Association, Dietetic Association, so what does a registered dietitian do? They set the priorities, they establish goals, they create individualized meal plans for the patient and foster responsible for self-care by the patient. That's the most important role. So you do a nutritional assessment like anyone that you would do normally. You do the diagnosis. So what all is needed, then you give the appropriate intervention, then the most important, monitoring and reevaluating whether the patient is achieving the goal, patient is keeping up, following instructions. That's the toughest part. And it's the toughest part of diabetes management is nutrition, adherence to nutrition. So nutrition intervention and RD does is plan meals and also find out how much carbohydrate intake they need, you know. Then they teach the patient about carbohydrate exchange methods. They also set goals, how they are going to do it. Because we all have different lifestyles. You can't always have a 8, 12, 6 o'clock meal plan. No, we all do different timings, hours of work. How do you help a patient to manage to their schedule? That's where your skill is coming in. So, and problem solving, what are the barriers? So I may not eat bitter gourd always. I may hate bitter gourd, but if that's really good, how do you make the patient to accept that? That's again, it's their skill. So how slowly can you change the patient from their set ways of likes and dislikes and eating to a more healthier dietary pattern that is really, really medically advisable for the patient? So does medical nutrition therapy really works? As I said, yes, clinically proven, scientifically proven, and in a long-term UKPDA study, we have it over, this is a study that's ongoing for 60 years. And we have shown that just by lifestyle changes, you know how much percentage we can prevent complications? 73%. Do you know what's the nearest medication that comes closest to it? Metformin, that's only 33%. So here you go, guys. So you have the impetus here, why your role is so important. And we have shown significant reduction in healthcare costs and also improvement in overall health outcome and quality of life. So macronutrients, you know, you guys are all nutritionists, so I'm not going to say major things, just going to zip through this. So macronutrients, of course, carbohydrates, fats, and proteins, and of course, water. I'm going to say it's an energy providing. So as I said, it's not a macronutrient, but in diabetes sense, it's very important. So these are very important. They help for the body to grow, repair, develop new tissues, conduct nerve impulses, regulate life process. So these all three macronutrients are very essential part of our life, and you cannot really disregard any one of them. So carbohydrates approximately gives us the 45 to 65% of our diet energy resources. So that's very important. It's broken down as glucose, the primary energy source, and that's the only energy source that your brain can use, nothing else but for sugar. So within 4 minutes, if your brain is not supplied with glucose, pure glucose, you will go into hypoglycemic shock. So that's how important that glucose is a very essential part, plays a major role, carbohydrates in your life. Proteins, of course, for repairing, regenerating body tissues, all those things, immune system, manufacturing of hormones, very, very important source. And I'm not going to talk further on proteins or fats. Fats are very essential for immune system and overall protecting our body functions and absorption of vitamins. That's very important in our body. Like without the fat intake, vitamin D cannot be. So there's, that 80 K vitamins needs fat intake for absorption. So it's very important. So water, as I said, is a basic need. It's very essential for our body. And water itself is a great treatment therapy-wise for diabetes. When your blood is fully clogged, saturated with sugar, just giving water itself dilutes, and water makes your kidney diurese, and you lose your sugar in the glucose in the urine. So it makes a big difference. Just giving water, hydration brings down the blood sugar by more than 100 points. Again, it's amazing how when the patients understand that and they feel really good when they are well hydrated. It's very important. So minerals and vitamins, when you come down to it, it's all the micronutrients, again, very important, which is very important for your body repairs, skin repairs, or your iron for preventing anemia and peripheral neuropathies, or your B12s, So we need to know these form a major role. So you have to make sure patients are eating adequate amount of variety of foods that all these are derived from. So your selenium, your magnesium, your antioxidants, phytochemicals, you name it, they all need it. And all of them do different various functions in our body. So how much of carbohydrates you need or its composition is seen for per day. In Indian dietary practices, unfortunately, we have very high carbohydrate diet. Approximately 65 to 80% even is carbohydrate. If you really think through it, like morning, your idli and dosa, it's primarily 80% carbohydrates. So even though we have red dal, but it's not enough. Are you adding a milk to it? Or are you adding an egg to it? So for a proper protein intake, and is there a fat in that? A lot of us, we don't. There are sometimes we only eat curd rice, nothing more. So is that a nutritious meal? Unfortunately, no. So we need to give a balanced diet. So what are carbohydrates? So carbohydrates are the major energy source, as I said. There are complex carbohydrates and simple ones. So complex ones are the ones we call polysaccharides. So they're starches, fibers, glycogen. Then the simple ones, essentially these complex ones are broke down, then our body really absorbs it. So, and the smallest one our body does is the glucose. But of course, there are certain carbohydrates our body does not take care of it. So carbohydrates are essentially present in almost all the major vegetables besides your grains, your cereals, also in major vegetables. So it's very important you are knowledgeable and you exchange this knowledge with the patient that you can't just keep eating your peas or your beets. It's just not enough, okay? And similar thing, people think nuts are great, doesn't have carbohydrate. Is it true? No. So your cashews have 27 grams of carbohydrates, one of the high carbohydrate. In fact, cashew is a no for a diabetes patient. Whereas if you have pecans or Brazil nuts, macadamia, they are low in carbohydrates. But these are, again, calorie dense. You have to be very careful about advising. They can have a handful, not more than that. Otherwise, they'll end up gaining weight, even though they are good carbs, but I mean, good fats with carbs in it. But again, just because they're good doesn't mean you can eat in an unlimited amount. So fiber is an important component. So this is where it helps to digest your food. It regulates your digestive system. It's widely available in grains, nuts, and fruits and vegetables. And a good healthy source of 25 grams is a really high. But if you really look into it, many of us, we do not eat that much fiber. Our fiber intake is less than 10 grams a day. So a lot of people have constipation, unfortunately. And when you increase the fiber content in the diabetic patients, be mindful of the medications they're on. Please make the patient drink a lot of water with fiber to prevent flatulence, and also introduce one fiber at a time. Let them get used to it for a week before you introduce So that's so important, especially a patient who is not a vegetable eater, who's a meat eater. So the basic fundamental in carbohydrate diabetes management is glycemic index. So what is glycemic index? So when you eat a carbohydrate food, it is the time how or it is a particular food, how quickly it raises the blood sugar and how high it raises the blood sugar. So I wish this is a didactic session. I can ask you guys which one. Of course, fruit juices are going to increase your sugar very high in a very short span of time compared to a whole grain bread or a whole grain, like matarisi or, whole grain rice, which is going to take a longer period of time. The glycemic index is not going to be that high. So it is how high and how quickly. And when it rises that high and rises that quickly, any blood sugar about 200, every time it touches about 200, you are damaging your organ. This is a very important point that patients don't understand that. They think, oh, it's just a 400. Oh, it's just a 200. Oh, it's just a couple. Overall, my A1C is 7%. Even though by means, they could have had high 10 readings and a few low readings would have mean level have come down. But then the high 10 readings is enough to damage the organ or cause end organ damage. So it's very important you advise low glycemic index foods for this patient. But is that enough? Because any glycemic index of greater than 70, the patient needs to avoid completely. And any between 56 to 69, you have to eat it with precaution. Less than 55, they should be liberally included in your diet. Whereas the glycemic load is the most important thing. So what is glycemic load? Glycemic load is where not only your sugar is how high, how quickly it increases, it's also how long it is high in your body, how long it lasts. That's very, very, very important also. So how do you calculate that? So you calculate the glycemic index with the amount of carbohydrate and you divide by 100, you get a constant, that's a ratio. So any low glycemic load, less than 10, is preferable. Anything between about 20 is definitely not preferable. So if you really go into it, here, I need to know a food that is low in glycemic index and that is low in glucose load. And that's probably ideal for me. So what's this food? Is there a food like that? Of course. So I do have a chart. I'll be sharing this later. You can go through. Chickpeas, glycemic index is only 10. Glycemic load is only 3 per serving. White rice, whereas its glycemic index is 89 and its glycemic load is 43. Obviously, this is not something you're going to use this. And so you want to replace that white rice with a whole grain that will prevent the patient from spiking their sugars. So like a whole wheat bread, it has a very high glycemic index of 71, but if you see the glycemic load is only 9, actually this is a very preferable alternative. So a whole wheat chapati is a very good alternative to compare to a white rice. Polished white rice is definitely not preferable. So this is again a knowledge that you have to help the patient, because many of us grew up on white rice. We love white rice. Who's going to eat the whole grain or unboiled, unpolished, big rice? I mean, it is a rather, what would I say, a learned liking, and it's not the one that you would prefer immediately. So these are the terminologies that's very important in diabetes management. So the third terminology I would like to introduce you is carbohydrate exchange. So what is carbohydrate exchange? So if I am not able to read, I am an illiterate person, will you teach me to do this calculations, all these things? So luckily we have a preconceived, prepared nutrition thing where 1 serving size is equal to 15 grams of carbohydrates. So we have a list which says, like if you say rice, 1/3 cup of a rice, cooked rice, is equal to 15 grams of carbs. So we have an exchange list prepared for each one of them that the patient can simply look at the chart and say, oh, okay, I can have 1/3 cup of rice, I can have a 1/2 cup of milk or yogurt, and I can have a 2/3 of peas, or a combination that the patient can immediately look at the chart. It's easy to pick up, easy to understand, easy to use. So we call this carbohydrate exchange. So when we say 1 exchange, 2 exchange, 3 exchange, that means it's equivalent to 45 grams. If it's 3 exchange, it's 45 grams of carbohydrates. If it's 1 exchange, means 15 grams of carbohydrates. So up to per meal, we recommend 45 grams of carbohydrate exchange. So it's really an awesome way for a patient who does not want the complication. There's amazing pre-prepared lists that you can give and tell the patient, eat this and follow exactly the quantity. So they have the variety too. It really helps. So what is carbohydrate counting? And that's the final one. This is actually the scientific way of managing the diabetes. So this is not an arbitrary like glycemic index or glycemic load or your carbohydrate. This is actually you're counting the right amount of carbohydrate. It could be 11 grams, it could be 38 grams, it could be 46 grams. Doesn't matter that you have this exact value to count the carbs. Yes, it matters, especially in type 1 diabetes. Because remember, 1 gram of carbohydrate increases sugar by 5 points. If I'm eating 10 grams, I'm going to put 50 points of my sugar. If I'm already, blood sugar is 200, I'm adding my blood sugar, another 50 points over, my sugar will shoot up to 250 in 2 hours after that meal. So it's very important that even that 1 gram matters in a type 1 diabetes and also in a type 2 diabetes, especially in the patient is on insulin, because we cannot match the insulin to the amount of carbohydrates. So if I give 1 unit of insulin, which was supposed to take care of 15 grams of my carbohydrates, but here I am eating 45 grams of carbohydrate, my 1 unit of insulin is not going to cover. So I'm going to end up with high sugar. On the other hand, if I am taking 3 units for that 45 grams of carbohydrate, that will cover my carbohydrate and I will definitely have normal sugar. On the other hand, here I go, I take 3 units, I decide I'm going to eat 45 grams of carbohydrates, but I only eat 15 grams because I'm not hungry. Here I have too much insulin in my system, I end up crashing, having low sugars. So it's very important to match your insulin, especially if a patient is on insulin, a type 1 diabetes patient, and the amount of carbohydrates they're eating. So timing of the meals, the amount of carbohydrates, timing of the insulin matters. And this is actually the scientific way to go about it. So how do I teach the patient to count carbs? Go with the nutrition label. That's the most important thing. Most of them have, even India. I'm really happy this year and a half I've been come back home that you see there are lots of nutrition labels available and a lot of online informations you can actually look up and collate it. So I'm really happy that we can really teach our patients, and we are teaching enough. So the nutrition label is most important, the serving size that is involved. So, and the amount. So if the label, the total carbohydrates in this label is 17 grams, and the serving size in this container is 2, then 2 times 17, this whole bag of packet of biscuits, if I'm eating, then I'm eating 34 grams of carbohydrates. And if I'm eating half a packet, then I have to slash it back. I'll be only doing half of that. So this is what you need to know, and this will give me the exact. That means, do I have to count for my whatever that has carbohydrates? Yes, every carbohydrate that goes in your mouth, you have to count for it. And I have a beautiful carbohydrate working sheet, sample sheet. You can take a look at it. If you have any questions, you can let me know. So how many carbohydrates does a patient need, a diabetes patient need? So if you're taking 2,000 calories, then approximately 900 to 1,300 carbohydrates. So that's anywhere from 225 to 325 grams of carbohydrates per day. Actually, that's a little bit higher in patients who are obese. We will not go there. We will actually cut it back to 1,500 calories. So in that case, the carbohydrate intake is 100 to 130 grams per day because we want the patient to lose weight. So it's very important that approximately 45 grams of carbs. So in American Diabetes Association as well as Indian Diabetes Association, we recommend around 130. It's not hard and fast. It varies from patient to patient, age of the patient, the severity, other comorbid conditions, pregnancy, activity level. That's very important. Usually one serving size, we call it 15 grams of carbohydrates. So 3 to 4 carb servings per meal, that is 45 to 60 grams per meal. Snacks, we usually say 10 to 15 grams. And of course, boys and girls, we have to see where are in the growth phase, puberty, they need a lot for girls and boys. So I have the chart on the slides, you can go ahead and look at it. So having said about carbohydrate, we'll move on to protein, just again, various age-based protein replacement. I'm not going to touch more than that. I have the chart up there. Then fats, good fats. Basically, please help the patient to choose unsaturated fats because our diet is rich in saturated fat, very rich in saturated fat. So, and how much fat intake based on your calorie intake, we have that too. So I have a traditional meal planning that my dietitian does, literally tells the patient what they can have for breakfast, lunch, dinner, and snacks. So how much of carbs, how much of protein, how much of fruits and veggies. So this is actually your job. It's very interesting. It varies from patient to patient. You're tailoring to the patient. So that's the most important thing. So I have a meal plan right here. So a typical meal plan that involves an Indian diet of more than 3,000 calories and how a modified diet plan from a registered dietitian, especially a diabetes dietitian, is for an 1,800 calorie diet is given. Then gestational diabetes, is anything really important that is we have to really consider? Yes. Gestational diabetes, you are going to feed 2 people here. We can't restrict the carbs, but on the other hand, carbs can put the weight on, can increase the sugar. The higher the sugar, the baby can be a big baby and have a lot of complications, as we said. So you can't restrict, but you can help to choose the right carbs, right amount based on the weight gain, their sugar level. We very, very closely monitor. The sugar levels are kept very strict, 60 to 90 fasting blood sugar and a postprandial of less than 120. And we make them check, and based on that, we adjust the carb intake. And healthy carbs, of course, is highly recommended. And I also have a meal plan for GDM. So ICMR, Indian Council of Medical Research, and also Research Society of Study of Diabetes in India, they call it RSSIDI. So for Indians, for us, they do recommend 50 to 60% of carbohydrates, which should include cereals, mixed coarse grains, whole pulses, salads, and soybeans. Proteins 10 to 15%, fats 20 to 25, and also please consider whole fruits, fiber-rich fruits, restrict salt and artificial sweeteners, avoid alcohol and tobacco. So this is a recommendation from them. So from Indian perspective, like Bangalore, you're cosmopolitan society. Come on, cosmopolitan society, you guys. People come from all over the world, and people living in Bangalore eat different food. I know when I lived in New York, I ate everything and anything. So it's not just an Indian diet. So you need to know, not just Indian diet, Indian besides international diets, Mexican, Chinese, you name it. Boy, that's one thing having lived in the United States, helped me to understand diets from different regions of the world, also different regions of India. So dietary history is very important, and that's where my dietitian helped me a whole lot to help really come up with a meal plan for my patient. So culinary diversity, economic issues, whether they can afford the diet, you can give the diet. Can they afford? It's costly. Eating healthy is costly these days. But say if I can't afford all the 5 fruits, this time when I go to the market, I can have 1 fruit this week, and next week I can have the 2nd fruit, a week later a 3rd fruit. That way at least I get the variety in. So, or seasonal fruits, I can get it. And if I can get too much of seasonal fruit, I can preserve it. So that's what we used to do. All the peaches and everything, we preserve it for wintertime, because wintertime the fruits are very, very costly in Pennsylvania. So all I used to do is get the healthy fruits and vegetables in summer. I used to preserve them for winter. So you can be cost effective. This is again is in your hand to tell the patient how to do it. So a patient can really be turned off. You might think that's immaterial, that is, but actually it matters. Every dollar matters. Every rupee matters when the patient comes to you, because very recent they don't come or they don't adhere to your recommendations, either medications or diet. It's because they can't afford. So it's very, very important you're mindful of that and and give your recommendations accordingly. You know, so it should be very patient-centric. That's so important. Finally, my favorite is plate method. So very simple, straightforward. It's really where I don't even have to. It's self-explanatory. So a 9-inch plate, you divide it. Half of the plate you fill it with high, rich fiber vegetables, you know, and 1/4 it is grains, whole fiber, starchy vegetables and grains, and the 1/4 is whole, you know, lean protein, 1/4. So this is all I have to just eyeball. I need to learn the measurements. You're actually in carbohydrate counting, you're asked to measure, but you can do ways like, you know, thumb, what is involved, a handful, a palm size, a deck of cards, what is all. So it is equal to certain measurements. You can teach the patient to eyeball if they don't have the actual teaspoon, tablespoon to measure. And then on the outside, you have the fruits or a cup of milk or yogurt, you know. So this plate method is an excellent way to help your patients to decide quickly and easy to follow. So finally, before I end, you have to tell the patient to take time to eat. It takes 20 minutes for your brain to register that you're eating, that you're full. If you're going to just scarf down your food, you're always going to feel full. I mean, you're not going to feel full, so you're going to keep eating. That means you're going to eat more. So chew your food, eat your food, and swallow it, and it helps. Take food as a priority. Don't eat in front of the TV. You don't know how much you're eating. Really look at your plate and eat, then that really brings down the quantity. Also, don't eat out of the bags. Don't eat out of the boxes like pizza boxes. Plate your food so you know exactly how much you're eating. And again, don't join the club of finish your plate, which is a very Indian way of saying you have to finish the plate. No, that's where we do overdo things. So if you don't want to waste the food, don't take too much on your plate. Start with small quantities, but you don't have to. If you feel full, stop eating. That's a very important concept. Kids, how do you make the kids? It's so important, so important. We are diagnosing type 2 diabetes in patients or kids aging 10 years old. Ideally, there should be a disease of older patients greater than 45 years, or at least 40. We are diagnosing type 2 diabetes of 10-year-old because of morbid obesity. In India, it's very pathetic, very pathetic. And these are the kids that are going to die by age of 25. So how do you do it? Tell the kids. You have to teach the kids' parents, because most of them are obese when they come there. You have to teach them healthy habits and healthy eating habits, activities encouraged. A lot of kids are so lazy. They are just addicted to TV and the games. And unfortunately, little older kids are put in all sorts of activities that they don't have time to go around and do anything, or there's no safe place for them to play or playmates, unfortunately. So insisting on physical activity, eating more meals at home, eating out and ordering in has become a fad. Unfortunately, I feel so sorry about it. Very Western way of life is being followed in India, which should actually stop, and we should go back to what we used to do, is cook your own meal and eat. So finally, so eating healthy meal, whole grains, including a healthy weight, eating moderate portions, reducing the portion size, eliminating unwanted, unrecommended, or bad foods, we call it, making graduates, you can really put an end to diabetes. My studies that I couldn't do this session with the slides on board, but I will make sure that I will send the slide forward so you folks can take a look at it and email me if you have any questions. We can go into Q&A now.
Thank you, Dr. Aruna, for that extensive session. You have started with the pathophysiology, symptoms, treatment, pharmacology, and also emphasized on MNT. Thank you very much. Your points were really noted, especially the one which you said that when the HbA1c decreases by 1%, how much you can decrease your blood sugar to avoid the complications. Then emphasis was also placed on the gastroparesis diet, which is very important for us. And what happens when your blood sugar increases greater than 200 milligrams per DL, how it affects the organs. The use of metformin drug universally used, and we have a lot of PCOD cases also using the metformin drug. And the difference between glycemic index and glycemic load, and how you use these values which are low in glycemic index and glycemic load when planning the diets. The difference between carbohydrate exchange, carbohydrate counting, all this has added real value to our students, and we are extremely thankful for having given your time, and we are looking forward for having to see your slides. Shall I take the question answer session, ma'am?
Sure, please. Go ahead.
The first question would be, when do you consider glycemic index of foods and glycemic load when planning the diet for a diabetes? Do you consider glycemic index when it is given as a single food, or do you take glycemic load because the glycemic load of a food is the plate meal? So when we take a mixed diet, so can you just give us clarity on when do you use glycemic index and when do you use glycemic load?
So frankly, glycemic load is the most important thing we use in diabetes, because the postprandial, after meal sugar load, lasting longer. Like say pizza, you can actually have the sugars up to 4 to 6 hours, even 8 hours. Your sugars are there, because pizza is a wholesome food actually, which has a carb, which has all your veggies and the sauce and things, and meats if it's protein, then cheese on top of it, which is high fat also. So fat delays absorption, so absorption of your carbohydrates. So the carbohydrate absorption takes very longer. So if a person eats pizza at 8 o'clock in the evening, the sugar can be 300 even at early mornings, 8 o'clock. So that's how delayed. So the glycemic load as a whole really, really is important for us. Very frankly, we moved away from glycemic index teaching. It's purely carbohydrates. We go with carbohydrates, whole grain, complex carbohydrates. That is slow to cook, slow to digest, and it spikes your sugar less. So we do have, like, that means you stay away from fruit juices. You eat the whole fruit, not the fruit juices. That's how we say Coke out of the question, So that's basically more and more the focus of terminology, and our even scientific discussion is more and more focused. But when it comes to cooking, still glycemic load, and if a person is really planning a meal, should I use a sweet potato, or should I use a regular potato, or peas, or carbohydrates? We think that's a mix of very good carbs, but actually all three of them will put the sugars very high. So you need to make sure they have a spinach if they have a carrot, because carrot and peas and potato, all of them have very high carbohydrates. So patient needs to know. So that's where we say about the low glycemic index or glycemic load, if the patient really doesn't understand the concept of carbohydrate.
Thank you, Dr. Aruna. You prescribe SGL2 for diabetic nephropathy patients?
Yes, because actually diabetic nephropathy, as long as your estimated GFR is not less than 45, it's actually SGLT2 protects renal protective, actually it is.
Okay.
So it prevents renal failure. It is shown actually decreases protein excretion. It is cardioprotective because of decrease in blood pressure and decrease in weight, and overall improves the cardiac function. It is actually a very amazing medication that has, but next to metformin, that is the first medication that has come out that has positively decreased cardiovascular mortality. Other than metformin, none. So SGLT2, because of improvement in blood pressure, improvement in renal function. But once it's beyond stage 3 renal failure, then you have to use it with caution. Stage 4, stage 5, it's contraindicated.
Okay. Thank you, ma'am. There is a question from Mrs. Mary John. When we go to test fasting blood sugar, they say drinking water before the test is okay. Does this reduce the sugar level?
No, actually. So
No.
hydration is very important. The reason we want your veins to be popping up so that we can stick your thing. And because a lot of these patients, especially diabetic patients, are dehydrated, the veins actually collapse. We are not able to draw blood. So we actually give you. What I meant by water intake by therapy is you have to drink really like 2 liters, 3 liters of water in a very short period of time, like 1 to 2 hours. We recommend oral hydration therapy if the blood sugar is over 400 or 500, which drops the blood sugar. Not a glass of water or 2 glasses or half a liter water is going to do anything. So in fact, we do recommend drink adequate water so we can actually have a painless or minimal painless blood draw.
Okay. Thank you, ma'am. There is a question from Lakshmi Jitendran. Can you explain the relation between incretin and diabetes?
Incretin and diabetes, yes. It is one of the another major system and endocannabinoid system where there's multiple gut hormones are being right now studied, which plays a major role in carbohydrate metabolism. So incretin is very important with your satiety and, so hunger, it's very important. So when these medications actually helps in suppression of your satiety. Diabetic patients are very, very, very hungry. They always want to eat. High sugars make them very hungry, or low sugars make them very hungry. So incretin actually decreases the appetite. It prevents weight gain. It increases the plasma, the pancreatic cell function, better function, the alpha cells we call it, and also makes the liver intake of glucose very good. So it prevents the glycogen breakdown or prevents gluconeogenesis. So it is an all-rounder incretin mimetics. It's one of the best things. The biggest side effect of incretin mimetics is nausea, and the injectable incretin mimetics, biggest side effect is it causes gastroparesis because it slows down your stomach, GI tract. So it causes chemical, or we call drug-induced gastroparesis. So that is very important. If a patient starts throwing up, you get given a diet and comes after 2 weeks with diarrhea and nausea, feeling full, and here you have given a high fiber diet, patient has changed everything. And that's probably because of the Victoza, the injectable incretin mimetics, which is commonly used in India.
Okay. Thank you, ma'am. There is a question on, some say that gluten worsens the gut health. What is your take on it?
Gluten? No, actually, no. Gluten is actually a lot of myths and facts. I tell you, there's a topic of myths and facts of diabetes and nutrition. It's a beautiful topic we took, actually. Gluten, actually, it's no. So gluten is very important to your health. You don't have to follow a gluten-free diet at all. It is only applicable to patients who have celiac disease, where you have antibodies formed to gluten that lines the celiac stomach lining. So the stomach lining is practically denuded. It is absent. So then you're not able to absorb. So you end up having diarrhea and nutritional deficiencies. So it is because of, and it is considered a foreign protein and the foreign subject, the gluten, so your body reacts to it. It is seen in 1 to 10% of autoimmune disorders, we call in type 1 diabetes patients, is very important. So that is something all my type 1 patients will be assessed periodically for gluten allergy. If they have anemia or vitamin D deficiency, we always look out for celiac. So when they avoid gluten, the lining actually regenerates and everything goes back to normal. So that's the only thing. Otherwise, gluten is as good as anybody. You and me can have gluten as much as we want. It's actually part of the diet. It helps with weight loss and everything. It actually causes satiety. It's very good.
Okay. Ma'am, there is a question from a dietitian, Beena and Nayak. In carbohydrate counting, is it advisable to have a different ICR for breakfast due to decreased insulin sensitivity in the morning in type 2 diabetes mellitus?
Definitely. We have different ICR for each insulin to carb ratio, she is saying. So, and we have insulin to carb ratio. I didn't go into the details of it because not everybody understands what it is. It is mainly we practice for type 1, but type 2, to some extent, insulin dependent diabetes type 2, where their pancreas is not secreting insulin anymore. Yes, actually, we have different ICRs for different meals, actually, not just the breakfast. For breakfast, lunch, dinner, and snack, we have everything different for them. It is actually a very detailed one on that. So, and definitely if the patient has a very high resistance in the morning, which is very common in type 1 diabetes patients, we do have a very high ICR for them in the morning compared to later in the day or at night.
Okay.
So it's the insulin, amount of insulin to the amount of carbohydrate you're taking. It's called ICR.
Okay. Ma'am, there is
Insulin to
a very general question on what is the treatment for diabetic neuropathy?
So diabetic neuropathy, basically you have to eliminate vitamin B12 deficiencies, iron deficiencies, other causes of peripheral neuropathy. Local neuropathies are very common in diabetes where the nerve entrapment, nerves gets entrapped. And so you have to eliminate all that. So if there are nutritional deficiencies, give them back, mineral deficiencies, give them back. But over and beyond, then we have to give medications like gabapentin, and we have pregabalin, other derivatives, and antidepressants, TCAs, so which helps. Unfortunately, peripheral neuropathy is one of the commonest conditions, and it's a very, what would I say, very inconvenient one, and it can be very painful and disruptive to the patient. Once they go into extreme neuropathy, where they are not able to even feel anything, numbness sets in, then the patient is very high risk for developing foot ulcers and foot complications. Once they get foot complications, most of the patients start losing their limbs. And extensive foot surgery is most of the time ends up in sepsis and death. So it's very important to prevent peripheral neuropathy. That's why in pre-diabetes stage, even when the blood sugar is 100, it affects the sugars. So that's why when the patient comes to my clinic and say, oh, sugar only 106, or why would I bother? That's okay. That's okay. It's just 101. I'm like, no, 101 means your nerve is getting affected. You got to get it down less than 100. That's the seriousness of why even that 1 point above 100 is important to treat or address.
Okay. Dr. Aruna, when that someone had asked you a question on gluten. See, we know that the glycemic load is very low for the wheat flour. But what happens in an Indian diet is, we are trained we have a training under Dr. Vishwanathan, Dr. Mohan and Vishwanathan under the Diabetic Educators course. So they recommend, since an Indian always is not used to a wheat flour diet, we were taught to give a diet which had both rice and wheat. So we give them 1 portion of rice and 2 chapatis, or vice versa, depending upon the calories. So we used to believe in giving a split diet.
Yeah.
So what's your take on that?
I perfectly understand that. But very frankly, if that's so, that every Indian who has immigrated to Western countries, we should all develop a gluten allergy and we should be on gluten-free diet? No, because we automatically transfer to wheat diet. In the morning we get up, we are eating wheat muffins to wheat, anything wheat-based, cereals and toast and wheat-based pastas, and so we are all high rich in wheat diet there. So it's not just nothing. It's I primarily grew up only on rice, and here I am eating everything for 23 years there. That means I should have seen. We have a very good Indian community in southern Pennsylvania, and I have lots of patients. I haven't even diagnosed one patient with celiac disease. So it's primarily a disease of Western community, white Caucasian community, actually. It is not of Indian community. So I do not agree with that. So it may be a good way of getting the patient away from the rice by introducing chapati, but just because eating chapati doesn't mean the sugars are going high, because patients think, oh, I'm not eating rice, I can eat chapati, so I can eat 6 chapatis. Exactly. No, again, the emphasis on carbohydrates. How much that food has carbohydrate, how much you can have for that diet. for that meal. That's the emphasis. So I don't agree with that, frankly.
The thing is, maybe because our Indians who have become diagnosed diabetes after the age of 50 or 60 years, they are used to eating rice, and suddenly asking them to move to chapati might psychologically affect them. So we still retain both, but we calculate the calories. And another thing is, in chapati, you can count and stop. 1, 2, and stop. In rice, when you serve with a spoon, and if the curries are interesting, you might serve a little more. So therefore,
that's exactly what we make the patients do, because we have Mexicans, very much rice eaters, Japanese, very much rice eaters. It's not just Indians, okay? So what we make the patients do is we make them actually separate that 1 cup of rice. That's it. If that's what your recommended carbohydrate, 45 grams, is that 1 cup of rice, you separate it, and that's what goes for your sambar, that's what goes for your rasam, that's what goes for your thing. Unfortunately, that's what it is. You feel hungry, put extra vegetables on your plate. That's why you fill up half of your plate with vegetables. Correct. That's how you make it full. That cup of rice, if you are instead of white rice, use that matari, Kerala matari or whatever. That is because it's bigger rice or wild rice, it'll make you full. So, or even basmati brown rice makes you full. So that's where a nutritionist or dietitian has the thing to influence the patient, not me. You guys can do it.
Thank you.
So telling the patient what they can do it, you know. So now we have all these navadanyams, you know, all the millets. Yeah, millets, and can replace. Slowly they can replace with that, which is very good to eat with sambar, very good to eat with your thing. So slowly you can walk them. And now actually people are very, very aware of these navadanyam. A lot of patients are coming and asking here in India about these. Can I take this? You know, I'm like, encourage them. Yes, please go ahead, you know. So that's where, again, it's how a dietitian's role matters.
Yes. Even when we teach our students, we always teach them to give a multi-grain roti and not stick to one roti. So our students have also moved to millet diet planning. So Wonderful. They incorporate millets into the wheat flour and make the diet. We don't encourage a single grain.
Excellent, excellent. That's exactly. This is where, again, a dietitian comes up with the recipe to tell a patient, hey, if you have this, you can do this. So you will retain the same taste, you can enjoy the food, but this is healthier than this, you know?
Okay. That's all questions we have, ma'am. Extremely informative and very patiently answered, very clear how you follow your protocols in the US. And it's quite similar in India. And we do our diet counseling. We have a diabetic educators course offered in different parts of India. So a lot of our dietitians are opting for that course to be counseled, because diabetic diet is not a rocket science. It is how you counsel the patient and convince the patient on portion sizes. That is more important. So extremely thank you. Extremely grateful for having spared your time, and thank you for joining us. Over to Dr. Sundravalli.
Okay, thank you, Dr. Aruna. It was very, very informative. Even though we couldn't get your slides, but your modulation of voice and you put it across was so clear that without the slides also we could understand what you are, telling us. So it was very informative. And as Mary said, it is thankful to you for sparing your time and patiently answering all the questions which has put it up to you. And thank you, Mary, for moderating the session. And thank you all the participants for patiently being with us with this webinar series. So now the knowledge sharing, we had 3 series, and last week we had from NSI Bangalore chapter, we had the breastfeeding week series also. So for a month from July onwards now, for a 1 month, we had enough, almost 10 talks we had in NSI Bangalore chapter. So we will have a break for a month or so, and we will be coming back with a new set of series, webinar series in end of September, it may go up to October, okay, where we have the National Nutrition Week we have, and also the World Food Day comes in that period. So you can expect some more activities from the NSI Bangalore chapter. Thank you, one and all. It was a great day. Thank you, Dr. Aruna, once again for
Thank
your
you.
patient explanation and being with us. Thank you, NSI Bangalore team, my co-convener, Mrs. Mary Reggie, and a special thanks to Ms. Lakshmi Jitendran, treasurer of NSI Bangalore chapter, who was the whole and soul support of the technical team. She and her family were the technical team who were supporting us with this Zoom link, and it was going really wonderful. And all the participants who supported us for a month, I think a few of them are here whom we can see the names. Almost in all the webinars they were here. Thank you, one and all. And also our executive team, they are not here, only one or two are here, like we have Dr. Kanabur here, and we have another people like Jyoti from NIPSIT, then Sumati Swaminathan from St. John's we have, then Swarupa from Cloud9 we have, and then Banu Deshpande from GKVK. This is the whole team we have from NSI Bangalore. So thank you one and all once again. Anything to say, Lakshmi?
Ma'am,
Can,
I have posted the feedback link in the chat box.
Yes, yes,
Thank
yes,
you.
yes, yes.
can I
yes.
have the email address again? I can.
Lakshmi, can you chat in the chat box? You can put the email ID so that
Wonderful.
Dr. Aruna will be sending us the slides. We can share it with them. Okay.
NSI Bangalore chapter? Shall I put
Yes,
the?
yes. Aruna, we are putting in the chat box,
Yeah.
Dr. Aruna.
Sure.
Yeah.
Got it. Thank you.
Yes, done, Lakshmi.
Yes, ma'am.
Yeah. Any participant you want to write to us, there is our NSI Bangalore chapter mail ID is given here. You can write to us.
Ma'am, we can send the PPT to those who are filling the form, no? Feedback
Yes,
form,
yes.
no?
So
From
today's
their staff.
feedback form, whoever is filling it up, we will be sending the email, the PPT. Okay.